welcome to another episode of the Seamless Connection podcast. I'm thrilled today to have with me Joe Moscola, the EVP of System Operations at Northwell Health. Joe, thank you so much for joining me today.
Thank you so much for the opportunity. It's a pleasure to be here.
So, systems operations, I know you've done a number of roles throughout Northwell in your 17 years there. Maybe you can start with telling us what that covers or maybe what it doesn't cover so we can dive right into it.
That's a great question. It seems to be one of the most common questions I get. What does that mean exactly? I think I'm still trying to figure it out, but really what it means is I don't have a lot of fence around me in my role, which is an amazing thing. So it allows me to get involved in a lot of different things. On a day-to-day basis, I oversee our shared services, and more specifically within our shared services, those are departments like IT and digital. Those are things like real estate, facilities, capital, um, and really ultimately the team member experience, and then thereby the budget of our shared services, which is about a $1.8 billion part of our organization. There's a couple other NewCo, if you will, entrepreneurial businesses that I've created along with our team. And one of them is called Northwell Direct. So it's another area that I oversee and sit on the board now at this point. But that's a direct to employer strategy. I also oversee something called FlexStaff. That's a business we started when I was the head of HR, and it is a temp and perm staffing placement company that, again, both Northwell Direct and FlexStaff are two for-profit entities that hang off of the not-for-profit parent of Northwell Health. And then there's actually a third company that we started called Northwell Construction. Each one of these is aimed at not only providing a commercial grade product and experience, but then in many ways creating efficiencies and driving down costs. And I can certainly talk more about them later. But that's a bit of what I oversee. And then I just get involved in some areas that are pretty cool. Another example, we started a joint venture with an organization called START that we'd met through private equity, Warburg Pincus more specifically. And it's we finally just inked a deal, and it's focused on bringing phase 1 cancer clinical trials to our patients in a broader, more impactful way. So there's sometimes no rhyme or reason as to what I get involved in, but that's the best part of my job.
Yeah, that's fantastic. It's kind of every day can be a new experience, a new challenge, a new adventure, it sounds like.
Without a doubt.
But originally when you started, you were clinical, right? Is that, do I have that right from your background?
I was. So I started off as a cardiac surgery physician assistant. It was my dream at the time to work in cardiac. I actually had functioned as a pharmacy technician. That's what got me through college. And I used to go up at the end of, not only during my shift, but at the end of my shift, just to hang out and spend time with the nursing staff and the PA staff and just learn. And I was completely hooked.
So what drew you to that? And then what made you shift to the more business and operation side of things?
Yeah. So I went to St. John's University, and while I was going through my training, I would say I felt a connection to healthcare. It wasn't this incredible passion or this pull. It was one of those things where it was, okay, yeah, this seems pretty cool. Let me try that. Um, it wasn't until I did 2 elective rotations that I felt this, wow, we need to do more here. And they were actually 2 electives. One was I did a rotation as part of my primary care rotation on Ward's Island, which is just off of Manhattan Island, and it was in a men's homeless shelter. And you see things in this homeless shelter that you otherwise would only see in a textbook or perhaps a third world country. And yet here we are, literally separated by a river, to the one of arguably the greatest cities in the entire world. And it just seemed so profound and so such a dichotomy from what existed, again, just a river over a river. And it was one of those things where I just felt like, wow, there's got to be more that we can do here to help these individuals that are just fallen on the hardest of times. You talk about hopelessness and despair. I mean, you certainly see it in that shelter. The second rotation, and I will definitely work very hard to sort of lift the podcast up here, but the second rotation was I did a rotation in the New York City Medical Examiner's Office. And so, for context, the physicians or the pathologists are the ones who do the autopsy, and then the physician assistant gets to go out into the community, the environment, the natural habitat of where that individual, that body is found. And they become essentially like the on site detective, informing the pathologist of what they see in the setting and where they pass. And so it's one of those things where you see the same as I was describing before, the sort of hopelessness and despair of, yes, suicides, dual modality suicides. That's when the person really wants to make sure that like it the deed got done, right? But you notice that it tends to be quiet, very, very quiet. There usually isn't people around. You can see the signs within the their apartment in these cases where just you talk about loneliness and desperation. And then you go into other homes where you see the joy of life. You see the pictures on the wall. You see the family just outside. You see the neighbors who are huddled talking about the individual who passed away, and you see that joy of one's journey, even in although it's sad, but you see the moments in life sort of come to life. And it was again the sort of dichotomy that just really struck me as that real privilege of getting to be able to help people in those times where they need the most, they're the most vulnerable, the greatest levels of despair, and yet those where you can see the beauty of one's life and a life well lived. And so it was from there that I would say that's where I really got the bite, and just really set out on this desire to just continue to impact lives and do what I can. Um, and so, yeah, that's how I really got the bug. But your question also was, when did I decide business school or the administrative side? As I was working as a PA, I just found myself wanting to do more, back to those two examples. And the question that I kept trying to answer is, how can you impact more lives in a positive way on the biggest scale possible? And so that sort of pointed me in the direction of leadership and administration, and that's what I am still in pursuit of.
No, that's such an honest answer. I've talked to a lot of clinical leaders at this point, and that's exactly it. They have the journey starting with how they originally got hooked with helping on the one-on-one or individual scale, and slowly they realize what they can do is they can take it to the next level and next level and next level. So that's an amazing journey.
Thank you.
So now you've been with Northwell for over 17 years, and you've obviously been in a host of different roles, from clinical all the way through administrative to now you're running, it feels like, a big chunk of everything with no limits on what you can touch. How do you think about focusing your time on what's important? Because you've talked a lot in the past historically about the different kind of transformational questions that you face, or as a system Northwell faces, or any system today in today's healthcare system faces, whether it's digital transformation, whether it's build versus buy, whether it's virtual care versus in-person care versus elective and versus, there's just so many operational questions, clinical questions, financial questions
Yeah.
that you have to balance. How do you do that? How do you think about it? What do you prioritize, or how do you think about what to prioritize at any
You
given
know,
moment?
it's so interesting. I literally was mentoring someone today, and what I described is, as you elevate in your career and then thereby titles, what percentage of your time do you think you spend, and then should you spend on strategy versus tactical strategy, operations, and deployment and delivery? And those, of course, are percentages that change over the course of those roles, your career, et cetera. And so I often will joke around, like the perk of the job I'm in today, or the level of leadership perhaps, is it's fairly easy. It's you really get this great opportunity to focus on strategy and really thinking through problems and predicting future and learning from others, um, uh, and that's just fun and exciting. And yet then the other part of the job is removing barriers. So every organization, whether large or small, is always going to have some degree of politic. We have politics in our own families, et cetera. And so, it's managing through those politics to try and find velocity. How do we continue to remove barriers so that we can get to that meaningful work, and what I call have that meaningful work take place, but with positive friction. You don't want things to be so constantly smooth, everybody's agreeable at all times, and so a lot of times it's really just playing more of the role of mediator and moderator, where you're just trying to help and make sure that others are being heard, others are being seen, and that you're getting the collective opinion of everyone around the room. So it becomes much more about even managing the team, and getting the input from everyone that you've otherwise assembled around the table. And then after that, it's removing the barriers. Sometimes, we put up toll booths, and toll booths shouldn't be there. You need the easy pass lane, or whatever else other it's called in any other state. But you want that speed lane on the highway so that you can just keep moving things along. And look, that's one of the things when we talk about entrepreneurial and so on that frustrates most people is that adoption cycle, that utilization cycle within healthcare is so long. And a lot of people say, well, why? Why does incubation take so long? Why does it take so long for a medication that's in sort of experimental or trial phase takes so long to get to the point of me putting the pill in my mouth? At the end of the day, healthcare is about life and death. I don't think there's too many other industries that can actually say that. True to my stories, my anecdotes from why I love healthcare. And so, yeah, you've got to be intentional, you've got to be cautious, but at the same time, you've got to take measured risk. And so, we can always be functioning more efficiently. And that's ultimately what we're trying to do is get our organization. That's one of the perks of working at Northwell is we do very much work to think outside the box, to be creative, and then take measured risks.
And that's one of the things that struck me in terms of the common thread through what you've done is efficiency, driving efficiencies, whether it's clinical, operational, otherwise. But one of the ways that you've done it that's been different from some of your predecessors is that innovative outlook, whether you're talking about FlexStaff, whether you're talking about moving to more of cloud computing. And I know that some systems have really struggled with pushing that. Like you said, you do have to be intentional. You have to make sure it works. But to your other point about predicting the future, I'm curious as to what's helped you take some of these, I don't want to necessarily say aggressive moves, but more innovative moves more quickly than others in a similar role, similar size systems. You guys have definitely been more on the cutting edge for some of these digital transformation, healthcare transformational moves. What's helped you get there and get
Yeah,
there
good
faster?
question. Yeah, I think a couple things. One, you know, first question I think we need to ask is what are we trying to solve and why are we trying to solve it? And once you identify then through that the right question or the right gap that needs to be answered or closed, then you allow yourself to begin to look at solutions. Now, oftentimes, a lot of people just say, all right, let's bring in a consultant. Of course, no disrespect to consultancy, and let's see what we get. Um, what I've always challenged myself and our team is what's best in class through any industry. Don't let's just not talk about benchmark, but truly what is best in class. So especially as we think about the shared services, all of those entities that support the hospitals and the physician practices, they are our customers. So we'll spend a lot of time going out to our customers, trying to make sure that we understand. And honestly, that was one of the first cultural pivots coming in and leading the shared services, having the privilege to do so, was just beginning to talk to people. What what can we be doing better? And when you are met initially with uh, nobody from the shared service corporate has said that to me before or asked me that question, you begin to quickly realize once it's said the second time, the third time, um, that okay, we need to be doing a better job listening and acknowledging who our customers are. So, one of the first things, culturally speaking, we started to talk about how we're not going to call ourselves corporate. We're going to call ourselves something else. Corporate sounds so like stodgy. It's just, and it sounds a little bit more like there's a hierarchy, me versus you, right? But how do we create a balance in the organization? And it's a balance, and that's something that that's where we start. What we look for best practice, and then I really spend a lot of time allowing the team to talk through and it's not so much allowing as it's fostering the conversation. Who's doing what where? How could we be doing it differently? Uh, what's the investment that we need to drive said efficiency? And it's from that dialogue that we then sort of set the course, or at least our eyes on it. Now, two things in a large organization, there's some ideas that are just going to be like dynamite, they're going to go. But then there's some that I think you have to, in your EQ, emotional intelligence, you just got to see that, well, today may not be the right time, but we're going to work it through. And, you mentioned the cloud strategy. Um, not being a digital native in terms of my career, as you heard, um, I knew I read enough, discovered enough, listened enough that I knew the cloud strategy was the right strategy for us. We had a lot of folks saying, you don't need that. We can be on prem. We can still do all these other things. And it felt like it was the right thing. Um, we were aggressive to get a partnership signed, and in this case with Google. Um, but once we had it signed, I sort of put us into a different gear, a slower gear, so that we can allow the sort of acceptance of the strategy to take place. So sometimes I feel like there's, back burners and front burners. This is how I like to describe it to our team, where put it on the front burner, turn it on high, crank it, let's go. That's pure velocity. Others are get it. You know how you sort of some recipes you get it to boil, but then you let it simmer for a little while, and sometimes you get the best flavoring that way, right? That's the same thing that we do with some of these ideas. Um, look, the cloud strategy was get it to boil, then simmer. This joint venture for phase one trials, there are lives on the line because in my mind, and as we know, that sometimes the best cutting edge treatments are in those phase one trials. We're going to move as fast as we can. And in that example, we will have from first conversation to actual site being opened, time cycle was a year and a half, or will be a year and a half. So they're starting construction on the site today. In 6 months' time, that site will be open and seeing patients. And that to me is a really exciting thing. But that's where you've got to crank the heat and you've got to do more of the barrier removals, but also then making sure you're communicating as broadly as possible.
No, that's amazing. And you mentioned before that you had heard multiple times, this is the first time I've been asked that question, or, no one's asked me that before from corporate, quote unquote, right? What surprised you the most? Or let's say the top three things that you heard when people finally realized this was a real question and you were really interested in their answer. What surprised you? Like maybe you went in with certain expectations on maybe resource needs or something, but you came out of it being like, whoa, like we were completely, looking at left field here.
Yeah, so part of the journey that I've been on, I spent 7 years as the head of HR for Northwell, and at the end of the day, it all comes back to people, right? This is a people business. It takes people and technology, but largely people to care for other people. And what I found often is we pride ourselves on relationships, And so because there's a positive relationship, you know, oftentimes we would get, this doesn't work great and this is a real problem, but so and so's doing is so nice, is so lovely, they're doing a great job. And once again, there's sort of like a disconnect. I get it, great. We can be like super, affable, but we've got to be able at the same time. And I think sometimes what we find, and we've just grown so fast as an organization, the question I think you have to ask is, did the individual move and grow as fast as the growth of the organization? And look, sometimes you have people who are great at growth, and then you don't have, but not great at like maintenance, make sure it works like a Swiss watch. Or you have folks who are great at the maintenance and not good at the growth, or those who can't do the turnaround, right? We all have our different interests, and so it doesn't mean that don't throw the baby out with the bathwater, as the saying goes, but what's the right role for the right person? And I think what we have found is you've really got to spend a lot of time thinking about which player is in which position, and it's probably the absolute best use of your time. And I think that's what we ultimately have been able to do is put the absolute best people in the role of where the organization is, not only at that moment, but where you see it going for the next number of years or whatever that time period is. And, just because I said all that doesn't mean that the person has to be terminated. It just means that um, we've got to we've got to do a better job of figuring out what's their strength and then how do we get them back to that position of strength. Um,
And
and so,
that's,
yeah,
yeah. No, I mean that's, and I kind of see threads of that from what you've done from the structure of Northwell overall as an institution as well. You've said before in other interviews where that you're not a technology company, that your goal is to treat patients and keep them healthy, right? To back to your point of it's a people business. And with that though, you've actually made quite a few kind of dramatic, almost institutional changes in terms of moving away from the build versus buy conversation, moving more towards the partnerships, like you said, with Google and others, as opposed to thinking that you need or even want to do everything in house. Can you talk to us a little bit about that evolution for you and for the institution?
yeah,
Because
sure.
that's very different.
Yeah, and this is an exciting topic, particularly given the size of Northwell. Here we are. We're growing about $1 billion of revenue a year. We're 88,000 team members strong, and we're on the precipice of really being multi-state. And so you've got to the provision and delivery of healthcare is so complex. And in one way, when I was in HR, and even still today, when I talk to like high school kids, I often will say, whatever it is, whatever you want to do in life, you can do it here in healthcare. And it's really true. I mean, you want to be a chef, you want to go into marketing, you want to be in you want to be an actuary, whatever that career is, especially beyond the traditional nurse, doctor, NP, et cetera. Um, you could do it all here. The complexity of that is it's all here. And so, if you begin to think of healthcare not just as a health system, because that seems a little bit, I'll make a gross generality that's a little too square. Um, how do we think more as an ecosystem? And so, especially as the amount of revenue that we are able to bring in from just patient care alone continues to be squeezed and shrunk, um, because of declining reimbursements, et cetera. That's a whole nother podcast. But the point is, how do we get to market quicker? How do we spend less time and thereby money and effort doing so? And how do we have a greater rate of success? Now, sometimes the answer is going to be internally. Um, we wanted to build our own internal uh, chat GPT like capabilities within Northwell. And we gave that to our engineers and they built it. It's completely fenced in. What I mean by that is we can use PHI information, assuming I have access and authority to that information, and I can use it to help me, not only clinically speaking, but administratively. They built that on their own. Now, there are other examples where we then say, no, we need help on implementing this. One, we need a greater rate of success. Two, others just do it so much better. What's an example of that? Uh, a CRM, customer relationship management tool. We had a couple homegrown. We had a multitude of different sort of smaller solutions. This is a foundational item that we want to be able to build off of so that we can better understand the patient, the consumer, the customer, and making them into a consumer, and ultimately being with them on the journey, understanding their behavior. And so we went for a big platform that we can build off of, that we can put into multiple spaces. And that's why we went with a partnership with Salesforce. We wanted something that was robust, that was going to grow as we grow, and that we were going to learn from as they grow. And yet there's other incredible innovations coming out of some smaller startups, and what I would call the new ideas that no one else is really doing. And so there's some really fantastic examples of that. Companies like AI Doc, who we have a great relationship with, and they are looking at artificial intelligence and leveraging it to find incidental findings on chest X-rays, CAT scans, and helping us elevate the quality, and what I'll otherwise call near misses, that maybe we may have overlooked.
And how do you decide, for example, that last thing is very interesting to me, because you have on one hand the engineering team that did the chat GPT, again, some version of AI, right? But then you also partnered externally for a different version of AI. Where's the dichotomy there, and how do you make that decision?
Yeah, and look, this is still very much a work in progress because some of these ideas are so great, and you want to put the sort of the power of the brand behind it, because in some ways, where we see the gap that this innovation can fill, and then in other ways we're like, we're just curious to see where this go. We may just invest in the organization and let's just see what happens. When you're doing both, um, you want to say that oh, let's put all of our momentum behind it, and we're going to roll this out across the entire organization. We go through all of Long Island, into Manhattan, into Staten Island, Westchester, and as I said, hopefully soon into other states. And that's a tall order. I mean, that's a robust solution. So what we have spent a lot more time doing is really trying to look at the roadmap of the solution, their level of R&D, and how much that is, and the health of the organization. Look, one of the reasons why we switched from our current electronic record, and we have a multitude, but to Allscripts is we just Allscripts. Oh my goodness, to Epic.
I would have
We're,
been shocked on that one.
we were on Allscripts. Sorry about that. Wow. One of the reasons we moved to Epic is because when you look at what they're spending each year in R&D, when you look at the robustness of their solution, the integration of AI tools into the solution, ambient listening, you just begin to realize to go where our CEO Michael Dowling wants us to go, from a vision standpoint, and goals. We're only going to get there with a more robust solution than we have today. And in many ways, it's also allowing us to create these solutions that go really sort of end to end in the organization, create standards of care, which hopefully then reduce variability, which then hopefully, not hopefully, but will, it was proven and shown to reduce adverse effects.
No, that's fantastic. And in terms of when you think about robust solutions across the system, digital transformation is hard. And there are certain areas that lend itself to easier adoption, like you said, the simmer versus like the full speed ahead boil. Um, Virtual care through COVID, right? It had this moment of full on, raging boil, and now potentially has come back to a simmer. I'm actually curious as to your opinion on where that is. But there's lots of areas where it can be as simple as a glorified Zoom connection, right? Or it can be as efficient and productive as something that has data and analytics and, like you said, AI incorporated into it to drive provider efficiency, capacity utilization, increased utilization across system resources in the most appropriate way possible. How do you think about that? Because we've gone through transformational seismic changes across healthcare because of COVID
Yeah.
with virtual care. And everyone's been approaching it very differently since that point, right? So I'm curious where you guys ended up or where you're still figuring it out.
Yeah, I love this question. I mean, it's so interesting. It's so complex. Um, and I humbly will say, I've had some experience throughout the last decade and a half with telehealth. I mean, when you look at things like hospital and home, that's not a new idea. It's not a new concept. It's been around since the 90s. But for at that time, technology and reimbursement, it really just didn't take place. Early in my administrative career, one of the first things I had the opportunity to be a part of was, this is before New York State stroke certified centers. It was just as they were becoming adopted. Um, we had our neurointerventionalist at our tertiary hospital, and part of the what we created at the time was a telehealth program where we were doing telestroke at our community hospitals. And so this is going back to like 2000, that had to be like 2009, 2010. And it was great. I mean, we saved lives. I mean, you talk about impact. I know we saved lives. And then, okay, now fast forward, and this idea of telehealth continues to almost be on to, like you said, that simmer. Or maybe didn't even get to a simmer. It was still trying, you're using one of these tiny flames on the back burner. And then COVID hits, and it's like, wow, it just completely. Now, you certainly discover today um, psychology, teletherapy. I mean, it's almost done exclusively via, um, um, electronically. Um, and so you look at that and how some areas have just taken off and yet others haven't. I think two things come to mind. One, when you look at the amount of now VC, private equity dollars and where they're being spent, it is largely on those devices and getting more information in the home. Or in me outside of the clinical space. And so in one part it's all those other dollars that are part of the healthcare universe and that 18% of GDP that are fueling some of those things to become cheaper, more efficient, more reliable. Yet at the same time, we come back to then, okay, well, who's going to pay for it? And as those two worlds start to merge closer together, I think we'll see that speed. And really, the pay for it comes for really more of the conversation around value. What value am I getting from my healthcare dollar? And that's obviously a very broad term. That could as much be me, the employer, who's paying for, I'll say my employees, um, and what I'm getting from my health plan, or it could be me, the senior citizen, and what am I getting from my Medicare and my Medicare Advantage plan. And then what are you doing to keep me healthy? I think the more that we have conversations around health and value, we'll start to see them in. And then I also think the more we begin to see some of the shortages in uh, uh, people that can do these jobs. We could talk about nursing shortages, physician shortages. That arguably is where AI should hopefully help us fill some of the gaps, but it won't fill all of it. And so we'll definitely need other ways of sort of amplifying uh, uh, the coverage.
No, and that's exactly what we've seen across industry, even for systems as large as yours. I'm sure you have clinical coverage gaps, areas where potentially your wait times are longer than you would like, or you're having more transfers or inter-system transfers than you would like because access to one specialty is only available at the mothership versus at the satellites. So there's a lot of areas for increased efficiencies that I'm sure you guys have looked at, are looking at, currently working on. Take your pick.
Yeah, without a doubt. I mean, in some areas you look and we look at access. It is has been a number one priority for our organization for many years. But let's call out child development. I mean, such a need, so few clinicians in this space, you know, to shrink down that time to next appointment is so difficult. The supply and demand are just completely out of sync, and so yeah, some of these areas we're going to need alternatives to help us um, create the access that people expect.
Yeah, and you mentioned your CEO has a vision that you're helping kind of implement over the next kind of X number of years. What is that vision, and where are you guys on that roadmap?
Yeah, so we continue. One, we as an organization, one want to continue to broaden ourselves in terms of the value that we can bring to the communities. Let's continue to make healthcare delivery local, dealing with local issues, while at the same time we become a national brand that ultimately represents one of quality and efficiency and a customer focus. Um, those things when you think about the challenges that we have in front of us, whether it's on a micro or macro level, um, really either uh, will cause the demise of some organizations or places like Northwell. I think it'll allow for the sort of catapulting to that next level. And so, we pride ourselves on being an organization that does things a little bit differently than some of the more traditional players. Some of the ideas and concepts and programs that ultimately we're able to roll out is just really a function of our culture here.
Yeah. And I always like to close with the wish list because you never know what the future can bring. So we've talked about a lot of these emerging trends that you're already focused on and have been working on, whether it's AI, whether it's automation, whether it's early access to clinical outcome, improving trials or, drugs, or things as simple as having more value-based care and things that are actually focused on outcomes versus just this is what everyone does. Looking at all of these emerging trends, what are you most excited about? One, and then the follow up on that is if you had a wish list and you could say, I want this tomorrow for my system, whether it's build versus buy, whether however you get it, what is the answer to that part of it?
Yeah, I mean, one of the most exciting things right now is this interface between technology, digital, and then the provision of care. I feel like for the first time, we have tools coming into the space that are really going to increase the efficiency of the provider. You know, I think for a long time we've been sort of marred with the notion that like, oh, okay, here's this electronic health record, and really it was for meaningful use. So it was converting paper into right. So it was just a conversion of the way we did things, but not an evolution of the way we or a transformation of the way we did things.
Yeah, it's for
Uh,
it's for the billing teams, quite frankly. It's not for the providers.
Perfectly said. Totally agreed. I think this digital transformation period that we're in is really like changing the way we deliver care if we allow it to. And so I'm really excited about that. I guess in the context, my wish would be, and maybe it's more of a hope, with so much technology coming in. Um, I really hope that we don't lose the humanism in it. I think medical ethics, while it's been around for a very long time, I think we'll have a resurgence in terms of what we're doing and should we be doing it. As we get into the space of cellular and gene therapies, some really exciting breakthroughs. We're also going to see how expensive it is. And so we've not solved the cost conundrum. But we're going to be getting some of these insanely expensive therapeutics. How do you do, and then, here we are, and I would argue that uh, equity of care has stalled um, in this sort of post-COVID era. How do we continue on the fair and equitable sort of pathway when you have medications that are going to cost literally millions of dollars for a single dose? And that's here today, right now. And so, how do you make those choices? I mean, we know how we want to make those choices, but how do you make those choices when the mass, the N, is just so much larger? And so, yeah, that's the part that I think we've got to continue to be diligent. We've got to continue to be leaders on, and that's where we've got to have the right modality for the right person at the right time. That's getting back to personalized care, which we in the industry have changed the name of because it didn't really like sort of stick. But really, that's what we're talking about: is personalized care. I want you to treat me the way I want to be treated, but also at the same time with the right medication for me at this right time in my life, or the right modality. And I think if we can do that for each and every person, well, then that's the wish. That's where I wish we will be.
That's fantastic. Well, Joe, thank you so much for sharing your morning with us. This is such a lovely conversation, kind of diving deep into the brains behind the operations here. So, looking forward to staying in touch and seeing where it goes.
Thank you so much. It's been great talking with you.